السلام عليكم. أول شيء أحب أرحب بكم بالعام الدراسي الجديد وأتمنى لكم كل النجاح والموفقية إن شاء الله. أنا دكتورة نور سحبان، مدرس مادة جراحة الفم للفصل الأول. أول موضوع عندنا بالكورس الأول هو موضوع الأودونتوجينيك انفكشنز، واللي هو موضوع كلش مهم لطبيب الأسنان ونشوفه بشكل يومي بحياتنا العملية، ولازم أعرف شلون أشخصه وشلون أتعامل وياه وشلون أتجنبه. مادة الأودونتوجينيك انفكشنز راح تتقسم على 3 محاضرات. بأول محاضرة راح نعرف شنو هي الأودونتوجينيك انفكشنز، الميكروبيولوجي مالتها، الناتشرال هيستوري والسبريد اوف انفكشن. بثاني محاضرة راح ندخل بتفاصيل الفيشل سبيسز انفولفمنت، واللي هو بروجريشن كلش مهم وخطير للأودونتوجينيك انفكشنز. أما ثالث محاضرة راح تكون عن البرنسبلز للمانجمنت والتريتمنت مال اودونتوجينيك انفكشنز. راح نبدي ببعض الترمينولوجي للمراجعة. Inoculation. It is the entry of a pathogenic microorganism into the body without the development of a disease. While infection, it is the proliferation of microorganisms resulting in triggering the defense mechanisms of the body, which is the inflammation. So, inflammation, it is a localized reaction of vascular and connective tissue of the body to an irritant, whether this irritant is microorganisms, physical or chemical factors such as heat or irradiation, resulting in the development of an exudate rich in protein and cells. These defense mechanisms aims to eliminate the irritant with various procedures, while the mechanism of tissue repair is triggered. Depending on the duration and severity of inflammation, it is distinguished as acute inflammation, which is characterized by rapid progression, and it is associated with typical signs and symptoms of inflammation, which is redness, swelling or edema, heat, pain, and loss of function. If acute inflammation does not progress, if it not regress completely, it will become subacute, which is a transition phase between acute and chronic, or become chronic, which is this procedure lasts for a prolonged period with slight clinical symptoms, not like the acute phase, and characterized mainly by the development of connective tissue. Let's take pulpitis for example. Pulpitis, it is the inflammation of the pulp caused by caries, bacteria from caries entering the pulp chamber and causing the body to react to this bacteria in the form of inflammation. When we remove the stimulus, there will be healing of the symptoms, healing of the pulp. If not, it will progress to a chronic inflammation. The stimulus is still present, the bacteria is still present, caries is still present, so there will be no resolution of the symptoms. From its name, odontogenic infection, they arise from the teeth and its surrounding structures. Etiology, it could be from caries, pulpitis, periodontal disease, pericoronitis, infected cyst or tumor, infected extraction wound, or fracture site. The infection can spread beyond the tooth to the alveolar process and into the deeper tissue of the oral cavity, face, head, and neck. The odontogenic infections range from low-grade, well-localized infections, such as periapical lesion, which need to minor surgical treatment, such as extraction or incision and drainage and antibiotic treatment, to a severe life-threatening deep facial spaces infection, such as Ludwig's angina and cavernous sinus thrombosis, which we will discuss in details in the next lecture. Microbiology of odontogenic infection. The bacteria causing odontogenic infections are part of normal oral flora, which usually found on the plaque on the tooth, on the mucosal surfaces, found in the gingival sulcus. These bacteria that found on the odontogenic infections are primarily aerobic and anaerobic gram-positive cocci and anaerobic gram-negative rods. These bacteria cause a variety of oral diseases such as dental caries, gingivitis, periodontitis. But when these bacteria gain access to deeper underlying tissues, as through necrotic pulp or through deep periodontal pocket, they cause odontogenic infection. Almost all odontogenic infections caused by multiple bacteria. An average of 5 species of bacteria were isolated, and up to 8 different species were isolated from odontogenic infections. Both anaerobic and aerobic bacteria were isolated from odontogenic infections. Aerobic bacteria alone accounts for 6% only of all odontogenic infection cases, while anaerobic bacteria alone are found in 44% of the odontogenic infection cases. Mixed anaerobic and aerobic bacteria comprise for 50%. The most common aerobic bacteria found in odontogenic infections are gram-positive cocci, which is Streptococcus merelli group, in about 65% of the aerobic species, and gram-positive staphylococci. Minor aerobic bacteria contributors are gram-negative cocci, Neisseria species, and gram-positive rods, Corynebacterium species, and gram-negative rods, Haemophilus species. The most common anaerobic bacteria associated with odontogenic infections are gram-positive cocci, mainly Streptococcus and Piptostreptococcus, and the gram-negative rods, Provatilla and Porphyromonas species, and also Fusobacterium species. Other opportunistic with little rules, gram-negative cocci and gram-positive rods. What is the mechanism of mixed infection? How it will change from strictly aerobic to mixed aerobic and aerobic to strictly anaerobic infection. It will start with the inoculation of Streptococcus merelli group into deeper tissue and the synthesis of hyaluronidase enzyme, leading to destruction of the connective tissue, and the infecting organisms will spread through, initiating the cellulitis stage of infection. At the cellulitis stage, we will have mixed aerobic and anaerobic bacteria. With the metabolic bioproducts from the streptococci, which is the release of essential nutrients, the lowered pH, the consumption of oxygen, all these will lead to a favorable environment for the anaerobic bacteria to grow. With the growth of anaerobic bacteria, the local oxidation reduction potential is lowered further. At this stage, the anaerobic bacteria will predominate. which cause liquefaction necrosis of the tissue by the synthesis of collagenase. As the collagen break down and the invading white blood cells cause more necrosis and lysis, microabscesses will form, which then merge into a clinically recognizable abscess. In the abscess stage, the anaerobic bacteria will be the only organisms found in the cultures. Early infection appear as we said, in the cellulitis stage, we see predominantly aerobic, but we will see some anaerobic, while in the chronic abscess stage, characterized by anaerobic infection. The odontogenic infection passes through 4 stages of infection. The first stage is edema. It starts from 0 to 3 days of infection. Pain mild, no borders, no defined borders of the infection. Size variable from small to large, it depends on the infection. Color normal, we see normal color of the mucosa or the skin. The consistency is doughy-like swelling. Progression increasing, we see no pus in this stage, and the main bacteria is aerobic. After that, we will enter the cellulitis stage from 1 to 5 days. It has also diffuse borders, no defined borders. Size large. It's characterized by a red swelling, red hard swelling, and tender. Consistency, as I said, it will be hard. Progression increasing, also no pus at this stage. In the cellulitis stage, we will see mixed aerobic and anaerobic bacteria. Then we will progress to the third stage of the infection, which is the abscess stage, from 4 to 10 days. Here, the abscess is well localized, small in size compared to cellulitis. It's characterized by a shiny center due to the presence of the abscess. Consistency soft, or we say fluctuant. Progression decreasing, because we in this stage we are near the completion of the infection. We are approaching the resolution of the infection. Pus, of course, when we say abscess, which means we have pus in the abscess also, which means closed area, no oxygen, so anaerobic bacteria present. The fourth stage and the final stage of the infection is the resolution stage, when the abscess drains spontaneously through the mucosa, through the skin, through the pulp chamber, or drained surgically by the dentist. The immune system will destroy the infecting bacteria, and the process of healing and repair will start. The natural history of a progression. As we said, we have two major origins of odontogenic infection. First, periapical, which is the most common origin of odontogenic infection. Bacteria from the caries reaching the pulp, causing pulpitis and then necrotic pulp due to lack of any treatment, and then spread through the root canals and reach to the periapical area. The first stage we will have, it is apical periodontitis, characterized by tenderness during percussion. If this apical periodontitis left untreated, it will lead to a periapical abscess. The other cause is periodontal as a result of deep periodontal pocket which allows the inoculation of bacteria into the underlying soft tissue. Direction of spread of infection. The infection may spread or inflammation may spread through three ways: through tissue spaces and planes, which is the most common route, or lymphatic system, or blood circulation. Spread of infection through tissue may appear as acute dentoalveolar abscess, which have various clinical presentation. First of all, intraalveolar abscess. It is when the pus accumulation occur in the alveolar bone around the tooth. As in here example, we have a periapical abscess. It's an example of intraalveolar abscess. If the infection or the pus perforate the cortical plate but not the periosteum, it will spread beneath the periosteum, causing a subperiosteal abscess, as in the example of palatal abscess or abscess around the body of the mandible. If the perforation of the periosteum occur intraorally, the accumulation of the pus will occur beneath the mucosa, causing submucosal abscess. If the perforation of the infection and pus occurs from the direction extraorally through the loose connective tissue, it will cause subcutaneous abscess. Sometimes it's spread through facial planes and spaces, forming a series facial space abscesses, which we will discuss thoroughly in the next lecture. شنو هو اللي راح يحدد لي هاي الانفكشن أو هذا الباس وين يروح؟ حيروح submucosal, subperiosteal, subcutaneous, الفيشال spaces. أكو عاملين مهمين يحددوا لي السبريد اوف pus. أول شيء اللي هو thickness of bone overlying the apex of the tooth. Pus associated with apexes near the buccal or labial alveolar bone usually spread to the buccal or labial aspect, while pus associated with the apexes near the palatal or lingual alveolar bone spread to the palatal or lingual aspects. For example, the palatal root of maxillary posterior teeth and maxillary lateral incisor, which has a curvature pointing palatally, responsible for the palatal spread of the pus, while mandibular third molar and sometimes mandibular second molar responsible for lingual spread of infection. Infection may spread to the maxillary sinus if the maxillary posterior teeth are embedded in the sinus or near the sinus. The other factor that determines the spread of pus or infection is the relation of the site of perforation of infection in the bone according to the muscle attachment in the maxilla or mandible. This will play a significant role in determining if this pus will accumulate as a vestibular abscess, if the perforation occur beneath the muscle attachment, or facial space abscess if the perforation occur above the muscle attachment. خلينا ناخذ بعض الأمثلة. أول شي عندنا relationship of mandibular posterior teeth ويا attachment of mylohyoid muscle. إذا كان apex مال lower posterior teeth above the attachment of mylohyoid muscle, spread of infection راح يروح sublingual space causing sublingual abscess، مثل ما الحال هي first و second premolars first molar. أما إذا كان apex of the teeth below the attachment هاي المايلوهيد muscle، إذا كان apex of the teeth below the attachment of mylohyoid muscle، spread of infection راح يروح submandibular space causing submandibular abscess، مثل الحال اللي راح يصير عندنا إذا infection spread من lower third molar. lower second molar هو 50-50 اعتمادا على اللينث مال الروت مالته. إذا كان above الاتاتشمنت راح يصير sublingual space involvement، إذا كان below الاتاتشمنت مال mylohyoid راح يصير عندنا submandibular space. مثال آخر عندنا اللي هي relationship مال upper و lower teeth ويا الاتاتشمنت من buccinator muscle. إذا كانت الأبيكس مال upper teeth above the attachment of buccinator muscle راح يصير عندي infection spread للbuccal space with external swelling. باللور إذا كانت الأبيكس مال tooth below the attachment of buccinator راح يصير عندي buccal space infection، يعني upper above buccal space infection lower below buccal space infection. أما إذا عدنا بالupper teeth كان الأبيكس below the attachment راح يصير عندي vestibular abscess و intraoral swelling. بالlower teeth إذا كانت الأبيكس above the attachment of the buccinator راح يصير عندي vestibular abscess and intraoral swelling. السبيسز involvement راح نشرحها بالتفصيل الممل إن شاء الله بالمحاضرة القادمة. Thank you.